So I don't know if this is a stat. It really isn't. It's more of a factual mission, and one that I can get behind. Philips is aiming to improve the lives of 3 billion people by 2025. So I think, obviously size makes a huge difference when trying to reach people. I think this is going to be a really interesting discussion around connected healthcare and how they kind of see that in the world. So I'm looking forward to bringing up. I want to introduce, let me take you to the next slide. I want to welcome them to the stage. Welcome them to the stage. I want to introduce Dan Monroe. Dan Monroe is not only a contributor at Forbes, but he authored a book in, 2016, called Casino Healthcare. And he is a writer and international speaker on topics of technology, innovation, policy that are unfolding inside one of America's largest industries, and that is healthcare. And just a little plug for later, at about 4:15 today, we're going to be having a book signing, and Dan will be here signing books. First 100 people will get a signed copy. So we'll kick it off with that. Thank you.
Awesome. Thanks a lot, Jill. Great to be back, as always, at the Digital Health Summit. And Haroon, it's good to see you again.
Good seeing you, Dan.
It seems like we're crossing paths quite a bit these days.
Every couple of months we run into each other.
Big fan of Philips. It's always amazing to me when I walk around or go around the house and realize how many Philips products are touch points.
Yeah.
In fact, a lot more so than necessarily software, which I also use, of course. But anyway. Key announcement yesterday with Qualcomm that I wanted to talk through, because hadn't heard a lot about 2net, and then all of a sudden it sort of came back into the limelight. So can you tell us, sort of what the thinking was that went behind that?
Well, if you look at Qualcomm, they're clearly the leader in connectivity. They're leading the charge on 5G. And they're specifically looking at these mission-critical use cases. What are the use cases that require this very high bandwidth, the very high reliability? And as we start thinking about where we want to take our solutions for healthcare, we're increasingly seeing that healthcare is being very much brick and mortar, confined to the walls of the hospital, and clearly everybody's talking about healthcare should be where you are. And that means that you need to have reliable connections. You need to be able to have a sensor network around you that senses you, that understands you, that adapts to you, and that gives you information about you. But also in the case of emergency, let's say when somebody has a stroke, needs to be rushed to the hospital, we need to know the background of the patient. Most of the people carry these big things. You've seen them, these defibrillators, sometimes monitors built in them. Mostly they're Philips, because we're the market leader in that space. But what we're doing now is we're connecting that. And it's not just taking the vital signs, but the vital signs only make sense if you put them in context of what you know about the person or the patient. And then when you get to the hospital, we need the same thing. We need the patient monitor to automatically know you. Because it used to be that you had to configure the patient monitor, but the patient monitor should know, this is Dan, this is Dan's background, this is Dan's medical history, and I'm going to give you more information about him. And that applies not only for monitors, it applies for the light. If you just come out of surgery, the light should be soothing and the noise level should go down. If you step into an MR machine, that MR machine should know what you're there for. It should configure to you and your procedure. So we have this concept of where the sensors, the devices, even the systems adapt to you. And for that, you need to have very secure, low latency, high bandwidth connectivity. And it's not just Philips equipment, of course. Lisa works for GE. We love GE. We're also competing with them now and then. But I think the reality in the world is that it's not just going to be Philips. If you look, my daughter is a diabetic patient, and she has a Dexcom glucose meter. I want that glucose meter to be connected. I want to merge that information from my health watch, which happens to be a Philips health watch, which is actually the only medical approved health watch in the world. But I want to mesh up that data. I want to maybe mesh it up with a Lilly insulin pen that's Bluetooth. And so our world's got to be open, and I think that's where Qualcomm and us find each other, because we share that vision of an open platform for Internet of Medical Things. And clearly pharma is also interested in this. So can we bring these people together on a secure, open, highly reliable platform?
So that's a key element too, is data security. And I suspect that had elements that were attractive and appealing relative to that kind of a partnership, as opposed to simply open Wi-Fi. So that gives you the kind of data security that becomes highly reliable and highly usable within a healthcare setting.
Yeah, of course, health data is highly sensitive, but so is financial data. So I come from the financial services industry, and in 1995, I was at Citibank and we launched internet banking, and people told me, you're crazy man. Nobody's ever gonna do their banking on the internet. It's not secure. And now I'm getting into the similar discussion. No, we gotta keep the data in the data center. We cannot put it in the cloud because it's too sensitive. Yes, it's sensitive. But you also gotta look at how do you secure information. You gotta secure it end to end. You gotta encrypt data end to end. You know why there are so many breaches that hundreds of millions of patients' records get stolen? That's because it's in a central database, it's encrypted. Sensitive data, at least identifying data, should be encrypted. So we have to rethink also how do we basically secure this stuff end to end? And then the next question is, how do we make sure that we give the right permissions on those data?
Right.
So if this is my data, but I want to share it with my doctor, but I also want to get his observations into my environment because I want to control my own health data.
Yeah. So about a year ago, you wrote a great article that talked about the three biggest challenges sort of in healthcare. One was change management, the other was reimbursement, and the other was patient engagement. And I mean, there's probably no other industry in the sense that has that kind of intersect with sensitive data.
Yep.
So out of all of those three, which do you see as sort of the most challenging on a global perspective from some of the implementations you've done?
There's a reason why in other industries, the whole personal connected 24/7 environment went first, because that's what consumers wanted.
Yeah.
And I think in healthcare, it has to start with the reimbursement system. It has to start with making a set of incentives that will drive towards these kind of solutions. If you're in a fee-for-service world, you optimize for fee-for-service. If you're running a radiology department, what you do is you do as many studies as possible, as efficiently as possible. I would do that if I was running a radiology department. But the real question is, to what extent does that radiology study contribute to a better outcome of the patient? That question is not being asked because there's no incentive to ask that question. There's no incentive to help a patient adhere to their treatment plan. There's no incentive to deal with the 50% of the people that don't take their medication on time. 50%. And this is an $800 billion industry to provide medication to patients. And half of the patients don't take their medication. Yeah. So I think the incentives should move towards creating better outcomes. And that will change the responsibilities. It will give more risk to the provider, but the provider will have to push some of that risk to the patient.
Right. So two of those sort of challenges came up relative to reimbursement and outcomes and the outcome focus. One of them was the NHS in Liverpool, which I think you referenced as self-connected care? And
self-management.
Self-management.
So it's interesting, a little over a year ago, I was invited to speak for the NHS, and the CEO of the NHS came ahead of me, and people started complaining, say, our ERs are, in the weekend you have to wait in the corridors to get to an emergency department. Our GPs are getting stressed out. There's a lot of burnout. Our system is squeaking at all sides. And so I started my presentation saying, well, I hear this problem, and you have a 28 billion budget gap. So you're not going to solve this problem within this model, because you're not going to build more ERs. You're not going to hire and train more GPs. So you got to look at it from the other side. Who are the people that are basically putting the load on the system? Right. Who are these people, and what can you do to serve them better? What can you do to give them better tools to control their own care, and not, with the first panic immediately call 911 and have an ambulance come, but give them an environment in which they understand their condition, they understand what they need to do, and they also have somebody that they can reach 24/7 that can guide them, help them, support them. And what we've seen, and of course Liverpool was one of the first cities that said, okay, we are definitely not a healthy city. A lot of type 2 diabetes, a lot of heart failure, but we recognize the problem, we know who the people are, and we want to change the system. We want to go to an approach where we educate people, we give them the tools to self-manage, we keep tabs on them, as some of them are the more expensive or likely to become very expensive patients. If we can, contact them now and then, if we can ask them to upload their blood pressure, their weight, their SpO2, then we can give them some guidance. If we ask them a couple of questions every day, we keep the situation under control. And what you see is what you see anywhere in these programs, whether it's North America, the UK, the Netherlands, or Germany. You essentially see 95% of the patient feeling better because they feel they're better in control. You see 40% less readmission for, condition-related issues, and you see 60% less emergency care. And it's a very simple concept, and we have to start doing this at scale, but we have to give the incentives to start doing it at scale.
So, and we linked up 2 years ago, in fact, at CES, and that was one of my all-time favorite stories up on Forbes is actually the super users of healthcare, which is a partnership between Philips and Banner Health in sort of my backyard, which is Phoenix, Arizona. And the statistics from that were pretty compelling, but beyond that, one of the key criteria for the patients in that cohort was that they have 5 chronic health conditions. So it wasn't just 1, it wasn't just 2. It was elderly super users of healthcare, and how do we keep them, in effect, at home? And so is there an update to that story?
Oh yeah, that's an evolving story, and yes, it was really honing in on the frequent flyers.
Frequent flyers.
And the results were quite amazing. And these are complex cases, as you said, 5 chronic conditions, elderly people, forgetful, sometimes onset of Alzheimer's. So you go like, how the heck are we going to support these people? But you make the technology really, a control point for an augmentation for those people. And you've seen that. You've seen people that hang on to their tablet, which is kind of their lifeline. It's their connection with the world. And we set up these 2-way video sessions, and that helps a nurse or intensivist guide these people, help them. But we're adding more and more technology. So number one, what we start looking at now is while we do the video session, we can actually, from the video, glean the vital signs. And it's an amazing technology that we actually developed for prematurely born babies, because you cannot put sensors on it. So we started developing these high-definition cameras where we had algorithms that interprets what they see, the movement, but also the coloring of the skin. And pretty accurately, you can read breathing, heart rate, heart rhythm, SpO2, etc. So while they're talking to us, we can glean the vital signs. We started experimenting with different ways of interacting. So, as you also know, Amazon Web Services is a big partner of us, and we started experimenting with Alexa, because we believe the natural voice interface is a very appropriate. You wake up in the morning. Did you sleep well? Do you have any swellings? Do you see it? Look at your wrists. Are there any swellings? Look at your ankles. Any swellings? And so you ask them a couple of questions. And you say, hey, 7:30, time for the red pill. Did you take the red pill? And it's all natural dialogue. And then, of course, at any time you can talk to a human being, or the other way around. People see, hey, suddenly there's a difference in voice. There's some tremor that sounds suspicious. Maybe we should reach out and talk to them.
A key element, though, of that partnership was the change management piece, in part because Banner actually retooled the delivery mechanism for this system by building out care teams, so it was more of a team-based approach. Did they do that, or did you help influence that?
No, I think we did it together. We went through that journey together, and it's as you said, it's kind of the second big challenge.
Yeah.
Because if you go to a hospital, and it's really the whole place is organized around disciplines, and everybody has an area that they're specialized in, and they're organized around that, and patients come and see them. So this is a different model. This is okay. We're a team. And guess what? We're looking at these big screens, and as I said, I come from financial services. It reminds me of a trading room, and so you have all this data streaming in, visualized, and it's a different kind of environment. You work as a team, and on the team is very interesting. Of course, you have intensivists, nurses, but you also have behavioral analysts, a pharmacist, because medication is a big deal, nutritionists, and all these people look at these cases together and decide what's the best intervention, what's the best, should we slightly adjust the treatment plan. But we also had interesting things, so just having these people come together, work as a team, but also, okay, we kind of forgot about the general practitioner. And say, oh, yeah, of course, they're part of this as well. But how do we fit that in? Because they're also used to a patient coming to them, making an appointment, sitting in the waiting room. And now suddenly the GP still plays a role as kind of the guardian. But you have to redefine those roles. And I have these discussions quite a bit. So what do we do with primary care if we creating these 24/7 triage hubs and response centers? I said, well, I still have a financial planner, somebody who helps me with my wealth. Maybe I should have a health planner that, given my condition, I have hypertension, and it's basically a high-risk hypertension. And just coming in once a quarter to measure my blood pressure is not going to cut it. Yeah. So I'm looking for much more guidance in my life. And, my daughter has a more complex condition because there's a lot of complications with diabetes. So can the GP help her to create her plan, set her goals, and maybe we can connect her to the GP as well. The GP becomes maybe the coordinator in the care team. Right. I don't know. We got to start redefining how we structure those teams. And guess what? I want to be on the care team of my daughter. Right. So put me on the care team. I want to help when I can. Right. And I think these models are where we should evolve to.
Atul Gawande actually wrote about this in 2011, so 6 years ago, where he talked about pit crews versus cowboys. And so that model is evolving and definitely changing. We're down to the sort of last 2 minutes. So
I still want to make one comment on the pit crew.
Yeah.
So, I started talking to the guys of one of the Formula One teams. And they told me, when we driving in a race, there's about 50 gigabytes that's streamed from the car. We know everything about the car. We have a crew that's completely attuned to it. We don't know anything about the crew and the driver. So now what we did here if you go to the Mercedes stand in the convention hall, actually we connected our health watch to the car. So when you walk up to the car, the car knows who you are, adjusts to you. So it will see, it will not only open the car, but it will say, hey, you're stressed. shall I help you relax? And actually the chair starts literally massaging you. Soothing music comes up, lights dim.
I love it.
But the other way around, you're sleepy, and it starts pushing you in the back. It's amazing.
Yeah. So that does bring me full cycle to sort of the last piece that we intersected on, which was at RSNA, and implementing what you're calling adaptive intelligence, but sometimes we refer to as artificial intelligence.
I see it as a subset of artificial intelligence. So the whole idea that we had with adaptive intelligence is that the technology is extremely powerful, artificial intelligence extremely powerful, but it has to adapt to the human being. It has to augment the human being. So our thinking was the radiologist should start using these very powerful tools and should actually teach the software about the best way to work. So there's a way radiology, in a cancer case, you do multiple studies and the radiologists will do hanging protocols, which still comes from the days that they would hang the films, but it's essentially looking at what has evolved. How did the cancer evolve? So we ask the system to learn from the radiology, and then we quantify everything. So you do 3 studies, we say, hey, this is the change in volume, this is how the cancer metastasized. And we even look, if you look at MS, which is, kind of a stellar constellation in the brain, it's very hard to measure the differences. And you may be a super neuroradiologist, but still it's impossible to quantify it as a human being. But the software can now quantify it. It can look at brain atrophy, and we all have shrinking brains, including you, Dan. But is it shrinking more than it should be shrinking? And if it does, it can be an early indicator of Alzheimer's. So we're starting to see these kind of things, and we're giving the radiologists the tools to look at that, but not just that. Looking at an image and seeing stuff is one thing, but you gotta look at it in context. So how can we tee up all the relevant information about the study of the patient? And then you look at blood tests, you look at prior studies, EMR data, but you have to make sense of it because they want to see it, in a split second. So we're now back to the training station. How do you visualize complex information and have somebody look at it and see in 10 seconds what's going on?
Yeah. Haroon, it was great. Thanks for
Dan. It was
dropping
a pleasure,
by.
always
Always enjoy it. Thanks again.